Pessoal, para a gente dar continuidade, a próxima sessão é sobre a radicalidade cirúrgica no câncer de colo de útero em estadio inicial 1A, 2A1. Vou chamar como coordenador o doutor Aguinaldo Lopes, Aguinaldo de Minas Gerais, professor titular de ginecologia da UFMG e diretor científico da Febrasco. Aguinaldo, grande prazer.
Bom, um bom dia a todos, né? Obrigado, Andréia, pelo convite, né? O evento EVA já algo consagrado no Brasil, esse evento de ginecologia oncológica de altíssimo nível, né? Que traz tantos colegas nacionais e internacionais. E parabéns mais uma vez ao Grupo EVA, né? Eu acho que nos representa muito bem com essa questão multidisciplinar, tem feito um trabalho em todos os aspectos do câncer, que no final das contas o que a gente quer melhorar a assistência às mulheres brasileiras com câncer ginecológico. Parabéns, Andréia, pelo super trabalho que vocês têm feito. E discutir agora, talvez, os assuntos que a gente tem mais falado nos últimos anos, né? Esse escalonamento do tratamento cirúrgico do câncer de colo, né? Por dois aspectos. Em casos selecionados, casos iniciais, a possibilidade de evitar a parametrectomia nessas pacientes e a biópsia de linfonodo sentinela também nas pacientes com casos iniciais. A gente tem uma mesa fantástica, tem um prazer de estar aqui a professora Plante, né, que é professora titular do Departamento de Ginecologia e Obstetrícia da Universidade Laval e autora principal do estudo que tem mudado a nossa prática em relação ao câncer de colo do útero, que é o estudo SHAPE. E também o professor Fabrice Lecouru, né, que é chefe de cirurgia de ginecologia oncológica do Instituto Curie, né, em Paris, França, que atualmente lidera o ensaio Senticol 3, que vai nos falar sobre o Senticol. E depois o grande amigo, que todos vocês conhecem muito bem, né, um super ginecologista oncológico, o Glauco Baiocchi Neto, que é diretor do Departamento de Ginecologia Oncológica do AC Camargo, para nos falar esse contexto local em relação a essas discussões. Para a gente estar um pouquinho atrasado, eu queria convidar, e temos também um painel de debatedores, realmente pessoal de altíssimo nível. Mas, para dar início, gostaria de convidar a professora Plante. Professor Plante, please. Thank you very much to be with us. Thank you very much.
Good morning. First, I would like to thank Andrea and the Brazilian GOG for their kind invitation for this meeting. I mean, it's really a true pleasure to be here. And I should say that I've been most impressed with what I just heard this morning. I mean, the media, social media campaign, the awareness, the promote vaccination, cervical cancer is just absolutely amazing and really impactful. So I congratulate you for that. And for now, we still have some cervical cancer patients, and we're seeing more and more early stage disease. And with the publication of SHAPE, we're now seeing some challenges and issues that we weren't thinking about before, so that I would like to share with you. So how to tailor the radicality in stage 1B1 disease, really. I'm sure most of you have seen or heard about the SHAPE trial, and certainly the conclusion was that the pelvic 3-year recurrence rate between a radical hysterectomy and simple hysterectomy is essentially the same. So what do we do now? How do we address the new challenges? There have been several prospective trials that have been published, as you can see here, and obviously the SHAPE provides perhaps the highest level of evidence, but it's important if we want to take it just a few minutes to review some of those trials. Number one is the CONSERVE trial, just because there are important differences between those 3 studies. And it's important to understand that in the CONSERVE, a cold knife cone was required to determine eligibility. And the cone margins had to be negative for cancer, had to be negative for high grade and AIS as well. And adeno grade 3s were excluded, LVSI were excluded. The other criteria were essentially the same. So very strict criteria. And if you look at the middle column, the simple hysterectomy group of patients following the conization, Despite negative margins, you could see that one patient still had residual disease in the hysterectomy, so it was probably hiding higher up in the canal, but no recurrent disease. In patients who just had a cone because of fertility preservation, despite negative margins, one patient recurred, meaning that there's still potential risks. And then we saw recently GOG 278 piloted by Dr. Covens, looking at efficacy and fertility after less radical surgery. It is exactly the same design as conserved, but I want to draw your attention that there are three main differences highlighted in yellow. In GOG, LVSI were allowed, pre-invasive disease at the margins were allowed, and a LEEP was allowed, not just a cone, but a LEEP. So those are the three main differences. And so just for your own information, this was published recently. One was about efficacy, showing that less radical surgery is safe in low-risk disease. And there's also another publication on physical function and quality of life, which is also better with less radical surgery. Now, if we put those three trials face to face, you can see it's quite a lot of numbers, but I'll walk you through. In yellow is a simple hysterectomy group of patients between the three studies. You can see that they're different in their design, but I want to draw your attention to the fact that we're looking at stage 1B1. In shape, we have 92% 1B1 disease, whereas in GOG, for instance, it's only about half of the patients. Again, LVSI was allowed in GOG, but we don't know how many percentage of them. It was allowed in about 13% of patients in shape. Very important, in my opinion, is the margin status. As you mentioned, for GOG and conserve, it was to be negative for cancer, but in shape, we allowed patients with positive margins to go on to have a hysterectomy. So it is not surprising that in shape, up to 46% of patients had residual disease in the hysterectomy specimen. And if you look at the recurrences in GOG and conserve is 0 following simple his, it's about 3% in shape. Why? Well, I think it's because we had more 1B1 disease of 92%, and also because we included patients with positive margins, which is really real life. But nevertheless, the outcome in terms of cancer death is very, very low. So it's based on these studies that NCCN has just published an updated version. And what they recommend in order to select patients for type A or simple hysterectomy is very strict. But they sort of played a little bit on the words. So they say that a cone biopsy is preferred as opposed to a LEEP. No LVSI is preferred. Negative margins is preferred. Adeno grade 3 excluded because they prefer just 1 and 2 adenocarcinomas and so on. So you can see that they are identifying in what I would call an ultra low risk group of patients. And it certainly would be very safe to use these criteria, but that would also exclude a lot of patients. Now, the big questions I get all the time is, MIS, is it safe? Can we do this in those patients? Well, if you look at the shape, unfortunately, and many of you are aware, unfortunately, the surgical approach was not a part of the design. It's not something we knew back then it was going to be so important. So as you can see, it was not a renovation factor in such a way that 3/4 of patients in the SHAPE trial had MIS surgery and about 1/4 had open surgery. So we did an exploratory analysis, which actually was published in January, and we looked specifically at patients with a simple hysterectomy, and we compared MIS versus open. You see again that 83% of simple hysterectomy in SHAPE were done MIS, and very few were done by open surgery. But we saw no difference in clinical outcome between the two approaches, as you can see here. However, in all honesty, you have to understand that there are limitations with this analysis. The surgical approach was not randomized. There were 5 times more MIS than open, only 15 recurrences, so it limits the potential for analysis. And again, it's a subgroup post hoc analysis, which is always subject to potential biases. I should also mention that even though there's no difference in recurrences between the two approaches, in the MIS group, we had 12 recurrences. 2 of them were carcinomatosis, and they both died. So that's a concern, the famous carcinomatosis after MIS, and the LAC trial has noticed the same finding. And so Pedro Ramirez did an editorial following our publication to say that the absence of statistical significance does not mean that there's no difference in outcome clinically. So we have to always keep that in mind. The other question we get all the time is, well, should we submit the patients to LipoCone with negative margins prior to doing MIS? So we did another post-hoc analysis, and it was just published in July. And we looked specifically at the patients in SHAPE who had a pre-hysterectomy LipoCone with negative margins. We found 174 patients like that. And we found 2 pelvic recurrences only, so that's right about 1%. There were no extrapelvic, no cancer death in patients who had negative cone margins, who had a hysterectomy by MIS. And so right now, what we can say is that SHAPE confirms that simple hysterectomy is safe if you follow the SHAPE criteria. SHAPE does not provide definitive evidence that MIS simple hysterectomy is safe just because the numbers were not very high. The risk of recurrence following pre-hysterectomy LipoCone with negative margins appears to be very, very low, but we need, again, more data to confirm this in a larger prospective trial. In the meantime, you must have seen the updated LAT trial results, which were published in May. And it's a long-term follow-up of 4.5 years that continues to show that MIS radical hysterectomy had a much worse outcome. And what's interesting in this new publication is Dr. Ramirez also conducted post-hoc analysis, and he specifically separated out the results according to tumor size. And what was somewhat surprising to see is that even in patients with tumors under 2 centimeters who underwent a radical hysterectomy, you could see that those who had MIS had a worse outcome than those who had open surgery. And of course, that was a lot worse following in patients with lesions between 2 to 4 centimeters. And so it made Dr. Ramirez conclude that standard of care for lesions under 2 centimeters remains open rad hyst, open rad hyst. So it's kind of a different conclusion compared to SHAPE. And then he did another analysis looking at the impact of cone biopsy. And interesting, on the right-hand side, which you can see is patients who had a cone biopsy prior to the rad hyst. The outcomes between MIS and open is kind of similar. Again, an interesting observation which has been noted by others. So SHAPE says simple hyst by MIS appears to be safe, particularly if the LIP cone margins are negative. And LAC says, no, open rad hyst remains the standard of care for those patients, and a prior cone appears to lower recurrences. So what are we going to do with all this? Well, the SHAPE, there's a new trial coming up. It's called the LASH trial, which is a composite for LAC and SHAPE. It's a prospective, hopefully international trial. It's single arm, and it's looking at patients specifically meeting the SHAPE criteria and recommended to have negative margins on their conization, having an MRI, and then they undergo MIS simple hysterectomy with sentinel node. It's looking at recruiting almost 1,000 cases. It's just started in that one center in Italy, and hopefully other centers will join so we can find out more of those information. And then the RAC trial, looking at robot versus open surgery, has been closed. And the ROC trial, I know many centers here in Brazil are participating, is also will give us more information on prospective trials about recurrences following MIS. So that being said, in real life, in our practice, well, assessing the SHAPE criteria retrospectively is very easy. But the reality is when we see patients, not that easy. There's all kinds of things coming up. and is always sort of unsure if we could do simple or should we do a radical hysterectomy. And assessing residual disease, tumor size, particularly patients who had a leap cone with positive margins, is very challenging. Why? Because you don't know how much disease is left. Because when you do the MRI, it's often inaccurate. How many times have you done an MRI that says there's no disease, but there is? Or the MRI says, well, there appears to be an uptake, but there's nothing. On final pathology, it was just inflammation. So MRI is not all that accurate after a cone. Clinical exam, again, it can be looking normal, but it's all up in the canal. You don't see it. So that's a problem. Now, I think it's important that you, if you have a chance to read this article, it's just published in June, the one at the top here. It's a retrospective study out of the United States from 2010 to 2020. It's commissioned on the cancer database, and they kind of looked at all their patients that had surgery for lesion under 2 centimeters, and I was quite impressed to see that 42% had a simple hysterectomy. The study was done in 2010 to 20, way before SHAPE was published. I'm like, oh, already? Almost half of the surgeons in the United States are doing simple hysterectomy. But I was absolutely beside myself to see that 18% of those who had a simple hyst required adjuvant radiation therapy. It can't be. I mean, these are patients with small tumor, low-risk disease, and they wind up with radiation therapy. So I was asked to write an editorial, and I compared the data to SHAPE. And in SHAPE, we had 9% adjuvant radiation therapy. Almost a majority were for patients who had positive nodes. And our 5-year outcome is 99%. So that tells me that if we don't select patient properly and they undergo simple hysterectomy, there's a high proportion or a higher likelihood that these patients, when you present them to tumor board, that will be recommended to receive radiation therapy. And it's terrible, because if that's what's happening, we haven't done services to our patients, because radiation therapy, particularly in younger women, has got a lot of impacts on sexual function, ovarian function. So we really, really need to be careful to try to avoid that. So how do we tailor radicality as the best we can? Well, those are my thoughts, and we can discuss. But I would say that for patients with visible lesion that looks under 2 centimeters, performing a large cone or leap to obtain negative margins might be the way to go. Why? Because then that provides a pathologist the entire lesion, and it provides a pathologist an objective measure of the size, the depth of invasion, the LVSI, and everything. So then you, as a surgeon, you have the ability to properly select the type of hysterectomy that you think fits this patient, and to select the surgical approach. The problem, so that's this. I mean, you remove all the lesion. The problem is if there is residual lesion, you don't know how much of the disease is present as well in the hysterectomy. So there's a risk of underestimating the size of the lesion. In fact, David Shibula, who just published the Centix trial, he noted in his study that 11% of patients that were seemingly 1B1 were upstage to 1B2. That's significant. And a simple hysterectomy for 1B2, we don't know if it's safe, but again, these are cases that might wind up with radiation. Measuring tumor size is a challenge, particularly, as Pedro said previously, if there's a leap cone with margins and there's residual disease in hysterectomy, the final tumor dimension is very difficult to assess, and there's a lack of consensus even as to how to do the measurements. I don't want to bore you with this, but these are the pathologists that they sort of say that we have to put all the cases, all these specimens together, like the leaps and cone and the hysterectomy report, and the pathologists should try to put it all together and give us the final tumor size, total size. I mean, my pathologist is not going to do this, and they say you can base this on reading the pathology from the leap and cone, which was done in another center. I mean that's not real life. I mean, this won't happen. So it's as complicated. The same thing also, the pathologist from the United States confirmed that there's a risk of under or overestimating tumor size, and that poses a challenge for the management. So 3 summary slides. I would say one, investigate and select the patients for less radical surgery very carefully. Remember that it's not all the patients with lesions under 2 centimeters that are candidates for simple HIS, and stay within the shape criteria. There is, it's normal, but we always tend to stretch the elastic a little bit. It's, I think it should be. No, it's not. So stay really within the criteria. And frankly, I'd say you'd better do a limited or a modified RAD-HIS than have your patients get radiation therapy. Think about it. If you plan to do MIS, I would suggest that doing a pre-op or pre-hysterectomy lip cone with negative margins is safer. Try to make sure there's no evidence of disease higher up in the canal. Remember that negative margins is not a guarantee that there's no disease in the cervix higher up in the canal. So I would suggest that you use protective measures, such as closing the cervix, and do not use uterine manipulator. And if the lip cone margins are positive, well, investigate carefully. Try as best you can to assess the true size of lesion. Some are reconing a second time the patients. I don't know. So that's a lot of procedures. And whether MIS is safe in those conditions, it's hard to tell. And finally, whether to shape or not to shape, I guess that's the question. And again, careful patient selection is key to avoid or reduce the risk of recurrence and to avoid and reduce the need for adjuvant radiation therapy. And remember, there's nothing wrong with a modified RAD-HIS, and there's nothing wrong with a laparotomy. Ultimately, we want good outcome for the patient. So, well, following shape, we thought we had it all figured out, but in fact, the management of early stage cervical cancer has become more complicated, I'm afraid. Thank you.
Thank you. That's just to sharing with us not just the data, but your thoughts regarding how to tailor surgical treatment in early cervical cancer. Para dar continuidade